Thank you very much. It's a great privilege to be here. I would like to thank the Chancellor, the Vice Chancellor, and the President of the Academy for the invitation. I have really two questions I want to address with you, share with you this afternoon. The first one, I think, is how does one engage with disability? What approach should one take? And I asked that question in frustration of finding the answer, because I did not have the sophistication of the thinking of sociology and philosophy and so on. And I came up with the answer in terms of what I regard as care and love and support that is part of, I think, a Christian doctrine. I'll say a bit more about that. The second question, in a sense, I hope helps Sister Helen in her engagement of the notion of how do we inform government? How do we understand policy making? How do we engage with this? Because I think it's actually very important. And part of my description this afternoon will be just to very briefly show you how that concept of government and disability is rapidly changing and being shaped by many things. To begin then with this first question about how does one approach disability, the United Kingdom has a very long history, as many countries do, of religious engagement with disability from the 19th century onwards. And I think the sad fact is that in a more secular society, religious voices are either made quiet or not listened to, or perhaps listened to but not heard, either way you want to put it. And I find that frustrating because the common good is there. People are very much, I think, switched on to the notion of helping each other and helping others. So in my formula, very simply put, care and support. And I then think this fits very nicely into Pier Paolo's idea of relational good. And I would like to develop that when it comes to the full paper, which I hope to present obviously in April, because I think it does have a resonance right throughout all the things I'm saying. So I do feel comfortable with the idea. I feel that listening to the discussion yesterday, with the various contributions, including the notion of dignity and the notion of spiritual or spirit, I find that very engaging with the idea of fostering a communication with different groups. And that brings me to the government in a minute. I would remind you that we have an established church in England. It's very unusual. Most countries don't have established churches in the way we do. And I also would say that part of that established church has unusually a seat in the upper house. Many of the bishops of the Church of England are there. And in a way, that is a conduit of thinking as well, that they can influence, they can engage with moral and important issues. So that's just a thought to begin putting together some of the ideas. I didn't want to start with the legal construction of discrimination and equality, because in many ways, as rightly pointed out just in the last speaker, it doesn't necessarily solve the problems, but I do think it creates a framework upon which problems can be dealt with. So to the second question, how does one engage with government? I just mentioned very briefly some aspects of this. Of course, we have a National Health Service based on what I call the Beveridge, or known as the Beveridge principles. And these are that, very simply, most social care should be given, health and so on the basis of need. A very fine principle. I think it's fair to say that that principle has come under considerable change, if you would like, reform even. And the reason is, of course, that was it ever intended to be all-inclusive? And the concept of a National Health Service already has gone. For example, devolved governments in Scotland, Wales, and Northern Ireland, they have a unity of policy through England, but they have money and they have differences and variations. So it's not national in the strict sense anymore. It's national in this aspiration, but I think that's a very important distinction in the way the delivery is made. But it's not the simple fact of the change in the direction of those principles having to evolve with new medicine and new costs and so on. It's to do with the notion that the public services include social welfare and care. And that has, I think, become open to a lot of discussion. When one looks at the health service in Britain, it's not delivered simply by the public money, it's delivered through contracts. As I put it, a whole series of different public-private splits. And that gives rise, I think, to the problem, and I think a challenge, as to how far one can rely on this model of the market in delivering what are, in effect, units of economic resource. And if you strip away the reason for those units of economic resource, simply seeing them as the delivery of whatever it is, it could be Amazon delivering a parcel as well as a healthcare unit, it, I think, takes away our humanity. And my concern, and that's why this first question is so important, is we have to remember what it is we're trying to achieve. Very briefly, in the last 3 years or so, there's been a lot of discussion with a national disability strategy. And it began in 2021. It's still coming to the end of that consultation period. And it covers three aspects of the delivery point. One is practical steps to improve disabled people's everyday lives. And the list is endless. Rights, perceptions about society, through housing, transport, jobs, education, and so on. And the reason I bring that into the discussion is this is the point at which consultation through stakeholders and so on has gone on. And to back to Sister Helen, it's where all the statistical evidence in collected. But don't think I'm getting off the hook that easily, because it doesn't necessarily follow that it provides a cognitive, holistic understanding of what it is to be disabled. Looking at it in a sort of Benthamite way of delivering goods and services, brackets health and education and care. And care has always been hypothecated on the idea that it's somehow different. And then from time to time, it's part of the health service, and other times it's not. The moment is now part of the health service. So now we've got the idea of health care and care. And it'll be interesting to see how far that goes forward. That's one aspect. Second is the experience of government of how to deal with disability and how that's treated. And there's a lot of discussion about how the feedback exists between the different government departments. I think I counted something like 15 government departments with different contributions to this healthcare strategy. And that gives you an idea of its complexity. And finally, there's an idea that the government should work across these departments and deliver all these strategies in the everyday experience of everyone. So those are the elements of it. But sadly, I think the arguments are that it may not, in fact, do enough to consult with the disabled. It's very good in terms of a model of how you present activities and actions and plans, but there's little detail on how the money is going to be spent or where the money will come from. And ironically, the disabled groups, when they first saw a first draft of this proposal, went to court and won a case in the High Court, showing that their consultation was in fact peripheral. They weren't really consulted in the way they should have been consulted. And then there's been an appeal against that. The government has changed various things and so on. But it shows that the dialogue which we speak of, this idea of reaching out, of being part of what we call the relational good, is absent in the way this was done. I think it's fundamental. It's a moral imperative to ensure that the bits are joined up for the people that are being helped. The other part of it is, and I may find this very, very interesting, some of the research post-COVID, yes, it has shown one of the tendencies mentioned earlier, that people who are disabled are going into work. 23% of the working age population is disabled. Roughly 53% of them can get some form of work, whether that's desirable or not. But the real issue is getting people into work. How will that work? Are there jobs for these people? And are there jobs for the people that will make their lives more enriched? So the question of COVID health impact is now becoming more and more clear. That is that the disabled were the worst affected as a group. They suffered because of ill health. They suffered because of the way in which they were isolated, and because many of them are at the lower end of the economic available resources. And I think that is critical to see that. Why is that? Why has that been allowed to happen in a society that could easily repair the damage of their economic inadequacies by giving them more help? One of the contentious issues, which is now the source of a lot of discussion, is how to make it possible for people to go into work by changing the banding of the different forms of contribution the state may make, and perhaps giving people more money when they are in work. How do you deal with those that cannot work? And so there's a big debate about the allowances and so on. I won't go into the technical details today, but you can get a sense of this, that one wonders, is the solution adequate to the needs of the people that are being encouraged to work? And the answer is that each person has got to be taken as an individual, as a human, and their needs need to be assessed in a way that does not take away their humanity, simply seeing them as yet another part of a large bureaucratic process. That's the danger, I think. I'm not saying it's inevitable that will happen, but it's one of the worries I have. So to bring this all together, I know time is short, I would simply conclude this. Helping others is easily explained, but there must be operational and practical reasons that we can, as a community, communicate to people why it is that they should help people as friends and neighbors, as part of the responsibility of being a citizen. And the thing that strikes me most about what I described about the United Kingdom is the paradox of it being so joined up, bits fit together, and there's cross discussion, communication. But equally, it is vulnerable to the small bits becoming weak that will weaken the whole. So, for example, the announcement yesterday of changes in the immigration status of health workers, it sort of slipped off the tongue in many ways. It was presented as, well, they will not have to be paid so much to get in, they can keep the existing arrangement, they will get a visa. But then it says, but you can't bring your family. And the implications of that are enormous for the delivery of these different services. And I don't think people realize it. Some of the care homes do in the private sector, but does the rest of society realize this makes a difference? The striking doctor, the poor relations, because of the enormous burdens they've all suffered over the last 3 or 4 years, has an effect in how they can do their jobs or how they can deliver the different things that matter to society. So what I'm saying is, when you have a very centralized, coordinated, highly technical mechanism for bringing together all the bits that make up our health service, private and public, one little bit can simply put the entire operation in jeopardy. And that, I think, is the closing point. That we forget why we're doing it. We forget that the outcomes are not necessarily quantifiable in terms of value for money and cost saving. What is the value of a human cannot be measured by an economic indices. Yes, it can contribute to our understanding of it, but ultimately we have to defend what it is that we believe in, which is that the virtues of morality must inform the outcomes of the economic settlement. Thank you.